When I got this topic, PET in head and neck cancer, and I was asked to speak against it, I thought it was very simple. I said, here is a thing which we don't use in head and neck cancer, so I should find enough literature to support my case and talk very easily. So I read it, and then I changed the title of my talk, Not Yet. I can't straight away and straightforward say PET scan shouldn't be used, but I would say that we are still not ready to use PET scan for head and neck cancer as a standard indication for staging and managing our cancers. So when I Googled PET and HNSCC in Google, I got 25,000 hits and similar number of hits in PubMed. And there is an increasing use of PET scan in cancer care today to detect disease, to limit therapy, to stage the disease, to monitor therapy, and to prognosticate outcomes. The unfortunate bit was that I didn't find too many negative studies for PET scan in head and neck cancer. So I had to really dissect data which was being presented in all the studies. So the issues of interest in head and neck cancer is that it's predominantly supraclavicular. Rarely do we find head and neck cancer spreading downwards. It is frequently in advanced stage, at least in our country, and multiple sites and subsites, each behaving very differently with respect to its metastatic potential to the nodes, to the spread along the submucosal planes, invasion of deeper structures, bones, etc. Therapy mostly is surgical and radiotherapy and or with chemotherapy. The use of systemic chemotherapy per se is not being shown to be very effective. There is a low incidence of distant metastatic disease, there is a high incidence of field cancerization, and there is limited applicability of systemic therapy. So I'll just bring forward one case. So while all this was going on, I had one patient who walked into my OPD. He had a superficial right tonsil lesion which was extending to the soft palate. There was a 2 centimeter node in level 2. I said, wow, this is the nice case. I must do a PET scan and have the CT scan, and I will be able to use these images for my talk. So the PET showed a high uptake SUV lesion in the tonsil, which was SUV of 16, and also a high uptake lesion in DV3. I am stumped. The neck node is not picked up any SUV, has not been shown to be FDG avid. Instead, I have something in DV3, and I did an X-ray. That vertebra looked absolutely normal. There was a small sclerotic area. Then I went back to the radiologist and said, what is this? So this is a bone island. This must be some increased marrow activity because he's an older person. So I'm totally stumped. So should I treat this neck node or should I not treat this neck node? So what do I want from PET scan in head and neck cancer? I want the PET scan to tell me what is the extent of disease. I want to tell me what is the status of the neck nodes, especially when the neck nodes are not palpable. I want to know what is the status of the contralateral neck, especially for lesions of the base tongue, the tonsil, and the hypopharynx. I want to know about synchronous cancers, which are known to be important, and we need to screen for them. I want to know whether there is any metastatic disease so that I don't end up doing a huge oropharyngeal resection for a patient who has metastatic disease. And I want to guide therapy reliably and reduce the morbidity of this surgery. So as far as detection of extent of disease, the spatial resolution of PET scan per se is slightly low, but the fusion of PET and CT does seem to make it a little better. But however, there is some coexisting inflammation which obscures the exact extent of the disease, and you cannot reliably detect superficial disease. And most importantly, the issue which I really want to know, the extent of the tumor submucosally or into soft tissues along the neural planes or along the blood vessels is not seen. So the extent of surgery for me still remains tactile and visual. Pre-surgical determination of margins is not reliable. I still need my frozen section at pathology by the pathologist, and I still need to depend upon the final pathology. So surgical therapy of the primary site does not seem to be affected by using a PET scan. However, as Dr. Ishita mentioned, when radiotherapy is the preferred line of management for this cancer, PET scan may be definitely used. So what do I do about the nodes? This is one of the studies which I found was pretty good because it used patients who had advanced disease. It was multi-institutional. Databases from 2 institutions were compared. Numbers were a little bit too small, but still, what do we see here? Sensitivity is good, specificity is okay, negative predictive value, not so good, but the positive predictive value is good. So it's reasonably accurate in predicting the nodal status. We may use it to limit surgery to the neck nodes, especially when it is negative. And it has been known, at least in other studies, that there may be a change in the treatment plan when you use PET scan in about 15 to 18% of the patients. Though the sensitivity is higher than CT and MRI, the specificity is lower, and hence PET cannot replace pathologic neck staging, especially in the presence of abnormal clinical or radiological nodes. So the most important thing for me is, if I don't palpate neck nodes, do I need to address this neck? Can I leave it alone if the PET scan is negative? And this study was published from Korea, 2006, 134 patients with no neck nodes, all of them no clinically palpable neck nodes, all underwent PET scan and a neck dissection. 26% of them had positivity. This is very much within this norms of what we normally see in literature. 26% of 25 to 30% of patients who have clinically no palpable nodes will have positive nodes and pathology. But the sensitivity of PET was abysmally low. It was as good as tossing a coin. And this increased with the size of the tumor. And the maximum was at 25%. So the overall, and can I extend this to the contralateral side, especially if I'm doing an oropharyngeal resection? Can I avoid doing a neck dissection on the opposite side because I don't palpate the node there? The overall incidence of contralateral neck disease is also similar, around 20 to 25%. It is higher in oropharynx, soft palate, and base tongue. And another study, which was published in Oral Oncology in 2011 with 114 patients, showed that PET CT is less sensitive than CT MRI, especially in assessing the opposite side of the neck. So we had our first time, we acquired a PET scan in our hospital in 2004, and since then we have studied PET scan in various cancers. And initial part of the study on head and neck cancers, it had 49 patients, and our sensitivity and negative predictive value were quite low, 71 and 82%, which is lower than what is published in literature, but nearing it. Today we have about 120 odd patients, and this percentage of sensitivity has increased to about 86%, and the negative predictive value remains around 88%. But the most important thing is, as far as the nodes are concerned, all studies have very small number of patients. They use multiple subsites which as I told you before, behave very differently. There's one meta-analysis which had a huge number of patients, and this meta-analysis, which compared 32 studies with 1,200 odd patients, showed that in patients who have palpable neck nodes, the sensitivity is 79% with a specificity of 85%. So 15% times you might still be wrong. And in an N0 situation, this is very poor. So the utility is limited in small nodes, nodes with small foci, less than 5 millimeters, nodes with necrosis, and in post-radiation residue nodes. When you add an ultrasound guided fine needle aspiration of this abnormal node, it outperforms everything, and we get the most accurate figure possible for saying whether this node is involved or not. But this is adding one more investigation and another technical endeavor, and then getting a positive result. So if I were to decide neck surgery based on PET, in an N0 neck, the general guideline is to dissect If the risk of positivity is 15 to 20%, PET scan does not pass the muster for avoiding surgery. In a clinically or radiologically positive neck, the need for pathologic confirmation of an abnormal node is not obviated. At least a selective neck dissection will be required. So using PET scan, I can't say I will not operate upon this neck. So what do I do about the synchronous tumors? Due to exposure to common carcinogenic insult, the entire aerodigestive mucosa is at risk of primary tumors occurring synchronously or metachronously. And the incidence of synchronous lesions is about 8 to 10%. The standard recommendation is to do a pan endoscopy. So quoting the same study which was mentioned by Dr. Ishita, 311 patients, 15 new lesions were detected on pan endoscopy. Another 30 lesions were detected when they used PET. But what was it? PET detected additional lesions in the lung, abdomen, and pelvis. 1/3 of these additional lesions were detected by the PET were within the area which was viewed by pan endoscopy. And half of these additional lesions detected outside the pan endoscopy area were negative for malignancy. So PET CT increases the detection of synchronous lesions by a small fraction. It, however, does not obviate the need for pan endoscopy. I still need to do the endoscopy. So I need to do an endoscopy. I also need to order a costly PET scan and then take another biopsy and go directed by the PET scan to the site which has been lit up. I'm doing the same thing over and over again. Value of adding PET routinely to low risk or early stage head and neck cancer is not justified with detection of synchronous lesions and metastasis. How about for metastasis from the head and neck cancer or detecting a second primary tumor which has occurred in this patient who's been struck by lightning twice? 589 patients were reviewed in this study. The prevalence was 8%. 10 out of the 589 were outside the aerodigestive tract. 16 out of the 26 lung lesions which were seen were parenchymal. So 20 plus 10 of the lung lesions were within the scope of the pan endoscopy which were missed. 9 were not seen on the PET scan, of which 4 were positive for malignancy. So where does it leave me? At any time, even after doing a PET scan, I'm still confused. 50% of my lesions don't seem to be either positive or not seen. So overall incidence for metastatic disease is about 6%. The range is between 2 and 18%. This is considered too low for routine use of PET scan to be cost effective, except in those with a high risk of metastatic disease, like in large oropharyngeal tumors, large hypopharyngeal tumors with multiple neck nodes which are almost occupying the entire neck or the lower part of the neck. Considering the nature of the head and neck, considering the nature of this cancer, local therapy will still need to be given to limit morbidity of this disease. We cannot depend only on systemic chemotherapy. Second malignancy is still rarer, about 2%, and hence routine use may not be approved. So what do I do with PET as far as follow-up for detecting treatment response, how does the treatment responded, and for detecting a recurrence in these patients? Most of these patients would have undergone surgery and or radiotherapy. Structural alterations following RT and surgery would make interpretation difficult, especially on CT or MRI, and PET is likely to add useful information for detection of recurrence. So in 2011 ASCO, this abstract was presented. 339 patients who underwent treatment. PET was less sensitive in 152 patients who underwent neck dissection. Of the 201 who did not have a neck dissection, 4% had recurrences, half of them were PET negative. And 12% who had no recurrences had a positive PET. So I really don't know whether I can use PET scan to monitor my patients post-operatively or after radiotherapy. So can we bet on PET? Head and neck cancer is a diverse group of tumors. Different subsites with varying behavior, amenable to clinical and endoscopic evaluation. Additional information from imaging modalities is small for treatment planning. Positive PET scan does not seem to obviate the need for further investigation. PET is a very highly sensitive investigation, but the specificity is varied. Advanced cases, it is extremely beneficial with the possibility of limiting aggressive therapy when metastatic disease is seen. Detection of synchronous or second primary malignancy can be a useful target for indication for using PET scan. A negative PET with a negative imaging is extremely accurate to the tune of 100%. If I did a CT scan and a PET scan and there was no nodes and no nodes were lit up, I would be rest assured that I don't need to touch that neck. The role of SUV max in predicting malignancy is still unclear, though there are studies today which say that a node which has an SUV max of more than 8 or a tumor which is more than 8 is highly suggestive of a malignancy. For managing local disease, it does not aid in avoiding surgery to the neck in the clinically node negative case, nor does it avoid the need for a biopsy of an imaging abnormality. It does not aid in surgical management of primary lesion. And irrespective of the findings, the need to explore the neck is mandated either by the likelihood of nodal disease, either for access to the primary lesion or for reconstruction. So despite the long history of use of PET and a possible ability to refine treatment with almost a third of patients, no large studies are present which address the decision change which PET scan makes in managing tumors of the head and neck. The result of incorporating PET in head and neck cancer in the final outcome in terms of survival, and how does it affect staging. We are looking forward eagerly to two studies which have been started, the RTOG 0522 and the Akron PET database, which will tell us more information about how we need to tailor and use PET scan in treatment of head and neck cancer. Hence, today we need to go with what is established and proven and written in our guidelines. The NCCN does not recommend it to be used routinely. And the Canadian guidelines recommends only where routine imaging is equivocal or where treatment may be altered for detection of metastatic disease. Thank you.